And then I do think it's really important for oncology nurses and all healthcare practitioners to really just be self-reflective and be as self-aware as you can of your own potential biases, your own unconscious biases, and make sure you're not bringing those to the table, that you're being open and honest and receptive to your patient regardless of what they're sharing with you, and not superimposing your own worldview, really being open to learning about your patient, what's important to them.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. Today we're talking with David Rice, who is the Chief Nurse of Innovation and Development at the Greater Los Angeles VA Medical Center in Los Angeles, California, to discuss the key aspects of delivering holistic cancer care to LGBTQIA+ patients, and we'll explain that acronym shortly, during all stages of the cancer continuum, from screening to survivorship. David facilitated a panel discussion on the topic at the 47th Annual ONS Congress in Anaheim, California on April 29th, 2022. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, David.
Thank you, Stephanie.
So, David, to start us off, let's recap some of the discussion topics that took place during that panel at Congress. What were some of the key points that the panel featured?
So thanks, Stephanie. And I really appreciated the session. I was really very happy with the enthusiasm from the audience and the attendance at the session, and then also the questions that we received at the end. Really, I think kind of shows a groundswell of interest for providers to gain knowledge on sometimes this population which can be hidden, right? You can't always necessarily know what someone's sexual orientation or gender identity is and how that impacts their care unless you're trained in it and you ask. And so I think the fact that so many folks, not only in the oncology care lines, but healthcare in general, and particularly with electronic medical records, there really is an interest in learning more about the population and learning how to deliver culturally sensitive and competent and agile care to LGBTQ people. So in the session, I did go over the general terminology of sexual orientation and gender identity. When we say that acronym, SOGI, sexual orientation and gender identity, we're talking first about the biologic sex. So people are born with genes, right? So they're either born male or they're born female, or they're born what's known as intersex or differences of sexual differentiation. And I'll touch on that briefly, but we'll encourage all of our listeners and all of our oncology nurses to do some independent study on intersex, because it is not a small population, and it may well be a population that individuals actually, that you will come into contact with in your practice. And in fact, I'll say that people who are intersex don't even necessarily want to be involved with this acronym of LGBTQIA+, because intersex people may identify as heterosexual or homosexual or bisexual, but it's not related to their underlying intersex condition. So again, I'll say a little bit more, but not too much more. Sexual orientation then is, who are you attracted to? Are you attracted primarily to men or to women or to both? So are you gay or homosexual? Are you bisexual? Are you straight, heterosexual man or woman? When we talk about gender identity, though, that's that deep personal sense of who you really are in total, and your gender plays a part in that. So your gender may match what you were born with, but it may also not match what you were born with. You can identify as a man, you can identify as a woman, or you may identify somewhere in the middle where you don't really relate to those binary terms of male and female. And so you might hear terms like gender queer, gender neutral, second spirit, two spirit, three spirit. One of the questions that came from the audience actually was, what is non-binary? What do you mean by non-binary? So non-binary, again, just means that you don't relate to either male or female. You have an identity that's somewhere in the middle on that spectrum. And then gender expression really is, how do you express your identity in all ways, and how do you express your sexual orientation and your gender identity? So it might be masculine, it might be feminine, or it might be androgynous. If you think of a lot of the popular music in the early 80s, right, the Eurythmics and some of the English pop bands, there was a real look of androgyny. Well, even going back to David Bowie, right, a real look of androgyny, not looking specifically like a man or like a woman. So how do you express yourself, and how does that outwardly express your identity? I do want to just make the point, though, that we are within those letters, right, within LGBTQ+, we are not the same within each of those groups. One of the health services researchers who's done a lot of work in this area is named Gwendolyn Quinn from New York University, and she makes the statement, what each group shares within the community is a common stigmatization as a sexual or gender minority for which little health research, particularly cancer-related, has been conducted. So you really could argue that the same as if you took a spectrum of straight people, right? A straight white man, a straight black man, a straight white woman, a straight black woman, a straight Asian woman, they're also not going to be the same. And so what do they share in common? And Gwendolyn's point is that what we share in common is stigma, the fact that we all have known some kind of stigma around our sexual identity. And you will hear that term sexual and gender minorities used more commonly in the scientific research. So when you see that versus sexual orientation and gender identity, you'll know that what that is referring to is just this identity. The common link is the stigma of being a sexual or gender minority.
David, thank you so much for explaining all of that to us. I think it's really important for folks to understand the acronym and the population. I think this is a really important topic for us to be talking about today. The LGBTQAI plus community was designated as a health disparity population by the National Institute on Minority Health and Health Disparities in 2016. Can you tell us a little bit, what does that designation mean for that population of patients with cancer?
Yes, there are a number of populations that are designated by the National Institutes of Health for health disparity status. And so what that means specifically for the LGBTQIA plus population when they received the designation in 2016, and for all other populations, is that compared to the general public, the population would have a higher incidence or prevalence of disease and disorders. They would have premature or excessive death in diseases where the populations differ. They would have greater burden of disease demonstrated by measures such as quality of life or disability-adjusted life years. And in general, they would have poorer daily functioning. And so for this population, there are a lot of factors that many of them may share that are determinants of social health, determinants of health that impact their ability to receive quality health care and also to receive quality cancer care if they do have a cancer diagnosis. So, for example, many of them may be underinsured or entirely uninsured. It was interesting, one of the questions that came up from the audience was about this population oftentimes not having primary care providers, but yet seeing specialists. So since this was a cancer audience, I would assume that question probably came from someone who was used to treating patients in a cancer specialty, but noting that they did not have primary care. And where that is true, oftentimes that can be related to cost. People just can't afford the care or the copays. Oftentimes it's related to stigma. So again, the feeling of being isolated, the feeling of being otherized and not being part of the broader population, and also fear of rejection. So fear that you're going to go into a provider and that provider is going to reject you based on your sexual orientation or your gender identity. Very often this population, although in the media we might think of it differently, but in fact this population tends to be lower income, lower socioeconomic status. So there might be low standards of living, an inability to afford basic necessities, high financial worry, and in fact, oftentimes LGBTQ people live in poverty compared to the general population, and oftentimes are unhoused or incarcerated. So again, compared to the general population in the United States, homeowners account for 63%, whereas the LGBTQ population, it's only 16%. Oftentimes, they may have food insecurity, they may have poor social and community constructs, so their relationships, their sense of community pride, involvement in the community, the sense of safety and security might be compromised. They may have purpose construct that they don't feel they have inspiring leaders, they don't necessarily have inspiring goals or see their own strengths or resilience. And then in terms of cancer risks, there are also data regarding cancer risks for this population.
So, David, you gave us a lot of really good explanation about what some of those health disparities are, as well as some of the systemic barriers that the patient population experiences. So, talk to us a little bit about how oncology nurses can address and overcome those disparities and barriers to care for our patients.
Absolutely. So when we think about how oncology nurses can really be helpful in overcoming barriers to care, it really comes back to what we do very well, which is getting to know our patients. So if we think about all of the identities that we're talking about just now, that's not a short list, right? It's not just, hello, my name is David, and I'm this age and I have this cancer diagnosis. You will, as an oncology nurse, be able to find a lot of these data in the medical record. You'll be able to find out where they live. You might have an assessment that would tell you, do they have challenges with transportation or do they have challenges with some other financial cost aspects? But as a nurse, you may also have to ask some probative questions of your patients so that you're really kind of gently getting at what are some of these issues in terms of social supports, family supports. What can the patient do for themselves in terms of self-care and what do they need help with? Keep in mind, too, that the definition of family has to be accepted to be much more broad in the LGBTQ population. They may well have blood relatives who are participating in their care, but they may also have chosen family. They may have a significant other or a partner. They may have people who are friends or colleagues who are helping them out, but who are not in any romantic way linked to them. So asking open answered questions is a very helpful technique for working with this population. Rather than make an assumption, you would want to be careful to be sensitive to the person who's coming in to see you. If you're calling out in a waiting room, you might say something like, patient Rice, rather than make an assumption that I'm male or female or non-binary. And then when you're in the room, you can ask questions such as, is there someone significant in your life? Is there someone important in your life? And rather than assume a heteronormative frame of, do you have a wife or do you have a husband? Leaving it open for them to share with you who is important to them. And then I do think it's really important for oncology nurses and all healthcare practitioners to really just be self-reflective and be as self-aware as you can of your own potential biases, your own unconscious biases, and make sure you're not bringing those to the table, that you're being open and honest and receptive to your patient, regardless of what they're sharing with you, and not superimposing your own worldview, really being open to learning about your patient and what's important to them.
What would some of the screening considerations for sex and gender minority populations be?
Well, I have to say, Stephanie, that the screening considerations in some cases, the research and the data are a little bit muddy. So I'll do my best to hopefully give a legitimate answer. In looking at some of the screening that's recommended by the national task forces, so for example, in breast cancer screening and cervical cancer screening, in some studies, and again, most of these studies are small and not randomized controlled trials, not large trials, many of them are even just descriptive of populations, you will see that sometimes there looks like there's a disparity with lesbian women compared to their straight counterparts or bisexual counterparts for breast and cervical screening. On the other hand, for the example of anal cancer, we have to think about the association then of HIV positive men or men who identify as men who have sex with men. These data are actually being kind of refreshed now by Joel Palevsky's group in University of California, San Francisco with his study. But even referring back to what Gwendolyn Quinn published in 2015, the overall incidence in the general population for men with anal cancer is very low. It's 1.5 per 100,000 person years. So for that reason, there's no screening recommendation at the national level for men of any age to have anal cancer screening. But if you look at HIV negative men, it is 5 times the rate. It's 5.1 per 100,000 person years. And if you look at HIV positive men, it's another 9 times that. It's 45.9 per 100,000 person years. And that rate actually is very much the same rate as colorectal cancer, which is the 4th largest incidence of cancer in the United States and has very specific screening recommendations. So for men who have sex with men, and particularly men who are HIV positive, many of them have found their way to clinics that will do, essentially you're doing a pap smear, but you're doing it of the tissue around the anus because you're looking for the human papillomavirus and you're looking for any abnormal tissue that then could be treated in a number of ways. But men across the country don't have that luxury. And even in my own practice, my primary care providers wouldn't really be all that knowledgeable about what you might think about doing for screening outside of screening guidelines. There are some cases, too, where because of the AIDS pandemic and over the years, particularly men who were diagnosed in the early years of the AIDS pandemic, where homosexual men may actually be over-medicalized, right? They spend too much time at the doctor and get too many tests because they've become hyper-vigilant about their care, and particularly if they have coexisting HIV and, for example, hepatitis B, a lot of maybe unnecessary worry and unnecessary screening and testing. So this is a long way of saying that there's a lot of research that can be done and can be done in a better, more scientific, more rigorous design studies way to identify and to collect data around what are the particular risks for screening for cancer in this population.
During the session at Congress, the panelists challenged healthcare professionals and then the attendees in the room to consider their assumptions about LGBTQIA plus patients. How can oncology nurses prevent implicit bias when caring for these patients?
Thanks, Stephanie, for that question, because it's an excellent one. And although I'm not on camera, I smiled, and I'll tell you why. I just came off of a meeting here where more than one person who were female persistently, when they're talking to the audience, and this was a committee meeting of 60 or 70 people, would use the word guys, hey guys and you guys. And well, we're largely nurses, so we're mostly women. And the fact that and I can't either, we can't really break that habit of just saying, well, you guys know, or you guys should do this. So it's not easy to break those habits. And one of the questions that I thought was charming from the audience members was, I'm old fashioned. I'm used to saying ma'am and sir. And so my thought when I read that question was, well, you might still be able to do that because you would get to know your patient. So you would get to know, if you called me sir, I'm an older gentleman, I would not be offended at all. But if you do have a 20-year-old trans kid, you might need to learn how to speak to that person differently. On the other hand, Stephanie, I do think that we can think about kind of the 80-20 rule where if I'm there as a gay man and another person is seeing the doctor next as a straight man, it's equally important to know about my bowel movements, and it's equally important to know about my sleep patterns, and it's equally important to do a med reconciliation with me as it is with the straight man or the straight woman or the next trans person or gay person who comes into the practice. So not to say that everyone is treated the same, and oncologists have made that mistake to say I treat all my patients the same. That is definitely not patient-centered care. But just to make the point that we do the physical exam, the head to toe, we do the chemo treatment, we do the immunotherapy treatment based on a huge number of decision trees and data points. And oftentimes your sexual orientation and your gender identity does not play into that. One of the questions that was asked at Congress, which I alluded to earlier, was how is a specialist going to do all of this screening if they're not seeing a primary care person? And although we didn't get a chance to answer that question there, my thought would be you would ask the question at every encounter only as it's relevant to you knowing your patient and you delivering quality, competent, safe, effective, efficient, and timely patient care. And if you've asked me once and you know that I identify as a gay male and I'm single and I don't have children, as long as you remember that or you read it in the record, you don't have to ask me that every time you see me. So that would be my response in terms of specialty care, which oncology is. I would say, too, that one of the blessings that oncology nursing have is that we know our patients for long periods of time. I used to work in bone marrow transplant, and I would take care of patients for years at a time, and I would see them grow their hair back and have children and reunite with their families. So I think that we have the opportunity, because cancer care is so multiphasic, multi-component, we have the opportunities to really get to know our patients and their family unit, whatever that is, their families, their communities. We really have an opportunity to get to know them very well and to share these very intimate moments of the entire cancer continuum, the ups and the downs, the good times and the very rough times with our patients.
I think that's a really good way for our listeners to take back and really think about things and how we do deal with all of our patients that we have. And you really do bring up a good point. I agree with you. As an oncology nurse, I think that we do have such unbelievable connections and relationships with our patients because they are sometimes really long term, and we do know everyone in the family. So that's a really positive thing. And I think if we look at that across the board with our patient populations, that I think we're going to do a good job. David, there were so many attendees that were asking questions during the session, and some of them you all did not get to answer. And so I wanted to cover in our episode today a few of them. And I'd like you to tell us how the panel may have answered some of the ones that they received during the session, or how you would answer some of these questions. So the first one I'm going to ask you is, an attendee asked, at my facility, at every stage, the OR, the ER, IR, inpatient, they ask gender at birth, gender identity, sexual orientation questions. When people get offended by the repeated questions, what is your recommended response?
Yeah, I do remember that question, Stephanie. I would say two thoughts that are, I think, complementary. One is thinking about the patient experience with that kind of questioning. One of the things that's very challenging for LGBTQ patients is the idea of disclosure. I have to disclose every time if I'm a cancer patient to my oncologist, to the nurse, to the radiation therapist, to the radiation tech, to a pharmacy, to housekeeping. You know, everyone that you come into contact with, you have the potential risk, and I'll use that word, of having to disclose your sexual orientation, either because you're being asked or, you know, an assumption that the provider on the other side might be making. So that's one part of it. Is if this were really easily identifiable in the medical record and communicate it in a way that everyone sort of sees that and knows that. And you've created a very safe space, and you've created very safe practice environments in your acute care and your ambulatory clinical care, your perioperative services, then you really would not need to ask those questions at every encounter with the patient. So that's sort of the gold standard that we'd like to get to, right? The ideal state we'd like to get to, where this is a piece of demographic data that's going to help us care for our patients. And it's also going to help us as we do research, because we don't know what we don't know related to how do a lot of these issues of sexual orientation and gender identity impact patient care and care quality. So, yeah, I do remember that question, and I respected the fact that it might be the way their organization is set up, that they have, I'm sure they're not on a paper record, I would think, but it may be that every one of those encounters that they listed, most of which were perioperative services, right, like interventional and the OR, that they might each have their own way of gathering data rather than having one central medical record that's going to be a repository for those data. But I do think that as we move toward medical records, electronic medical records, most of which, not to comment or opine on any of them, but in fact, they are billing systems, right? They are meant to trigger all of the financial records and the billing records and the HIPAA requirements and so forth. So as we get, though, to the use of electronic medical records in a more facile way, again, this will be a data point that's integrated by the nurse, by the user, by the surgeon, the interventionalist, whoever's looking at the record. And you won't have to ask 50 times in 2 weeks because it'll be readily available to you.
Thank you for answering that for us. Like you said, unfortunately, there are some facilities that have different systems in the different departments. And so it isn't consistent across the board. And I could see where patients are getting frustrated with the questions being asked, and they feel like they've asked them several times.
I will share, Stephanie, though, that the first time, and this was way back in New York many, many, many years ago, and it was a paper intake form, the first time that I saw on paper, do you have sex with men, do you have sex with women, or do you have sex with both? I felt really valued. So I didn't mind answering that question at all. It was the first time I had ever been asked it, even though it was by a piece of paper.
Exactly. I think there were some other questions that came up from the audience during the session that asked about electronic medical records or electronic health system records, and that the system records sex at birth, and then the employees would enter the patient's pronouns, but they said that occasionally the computer would decide the pronoun identifiers represented because of the sex at birth answer. So they said, that matters if there would be a need for a pregnancy test prior to initiation of chemotherapy. So how did the panel respond to that question?
We didn't get a chance to do any follow-up questions with the person asking it, but I do think, well, I read that question, Stephanie, and maybe you can tell me if I'm interpreting it the same way as you are, that they would record the sex at birth, but then sometimes based on, so for example, if they recorded me as male for sex at birth, then the system itself might populate he, him, his as my pronouns, for example. Is that how you're interpreting the question?
Yes, it is.
So I think in that case, well, it might be that it defaults to that because the identity is male, and then they may have, their system may be set up that the link is to he, him, his, and then the person doing the intake would need to change it if it were differently. If that were the case, I wouldn't want that system. I would want someone to work on fixing that system. But I do think it is an important thing for the audience to know, not so much for how that linkage was, but we do need to know the sex at birth because of billing records. So now I'm at a federal organization, so it might be different, but in the state of California, you do have to identify, and the state agency that collects it, I think now has 4 categories. So it's male, female, other, or unknown. So the 2 examples that I use, one is if you are a trans woman, and you still have your prostate because you were a man who transitioned to a woman. And so you have prostate cancer and you're being treated with external beam radiation. If you were recorded as a female in the record, you would not be able to bill for that. So that's one example where you do really need to know the gender at birth. But the gender at birth, two things. One is that it would uncover this idea of intersex, which I talked about a little bit earlier, and might uncover it, which is an important medical consideration. And the other thing is that it allows you then, as the clinician, to think about doing an organ-specific inventory. Some medical records now are built with an organ-specific inventory. So in my case, I would be checking off that I was born with a prostate, I was born with a penis, I was born with testicles. If someone has had gender reassignment surgery and they're coming in and they're doing an organ inventory, if they no longer have a uterus or a cervix, obviously you're not going to need to do cervical screening. But if it's a trans man who has not had any gender reassignment surgery below the waist, you would need to do whatever cervical screening or endometrial screening is recommended for the general population.
One of the things that we talked about in that last question that came up were pronouns. And there was an attendee who asked, I want to be respectful and ask my patient what pronouns they prefer I use to avoid assumption. However, I sometimes get backlash from patients in older generations. What language do you recommend using when getting backlash from patients after asking what pronouns they prefer I use to avoid assumption?
It is true, Stephanie, that if you're dealing with an older population, which the cancer population by and large is, they may be offended or they may not want you to ask this question at all. What I would start with when you first meet the patient on your first encounter, if they have not answered something by doing an intake form or an intake electronic form, what I would start off with is just, how would you like me to address you? And so that leaves it very open for them to say, I would like you to call me Mr. Jones, or I'd like you to call me David. And then you can go on and say, are there specific pronouns you use? I did appreciate our patient advocate who was with us on the panel, Sean, saying he would recommend that you not use the word preferred, because that kind of gives the impression that this sort of special treatment versus just the kind of pronoun that you would use. So to the extent that you could not say preferred pronouns, but could you say something like, how would you like to be addressed? And are there pronouns that you prefer to use? Or are there pronouns that you'd like to use? I think as we go on this journey, we'll get more comfortable with that. I will confess, Stephanie, that because I'm sort of down the left side of that slide where I born male, I identify as a male, I identify as gay, and I express myself as male, I don't really think so much about pronouns for me because I just identify as male, and so I assume that someone's going to refer to me as he and his. Whereas people that may use they, them for pronouns really throws some people off because it's a plural, and so it confuses people, like, what do they mean by they go by they? So I would say we're doing it out of respect for the patient, and we're doing it out of respect for the patient's considerations about how they receive care. And if you have an older patient who finds the intake offensive, then I would just stop at that point. You say, how do you prefer that I address you? And then, Mr. Jones, let's go on to the next question.
So one last question that we are going to be able to go over today with our time is another attendee asked, do you have any suggestions on particular screening tools that we can give to our patients?
I would say, Stephanie, when I read that, I don't know that I would really know how to interpret the question unless you have a sense of how you would interpret it. Screening tools that are used based on national recommendations. I mean, again, I think it comes back to that idea of doing an organ-specific inventory. So we know that there are recommendations for prostate screening in older men, but it's a little bit of a moving target, right? The PSA is not the most reliable tool. And then once you've reached a certain age, you're going to have prostate hyperplasia anyway. So is it really worth doing PSA screening on an 85-year-old? Probably not. But we have very specific recommendations for breast cancer screening and for cervical screening and for colonoscopy. Those don't differ based on your sexual orientation and your gender identity unless you have an organ that doesn't match how you're expressing your identity. Dr. Dizon gives a very compelling example where he had an older patient and his wife come in for evaluation for ovarian cancer, and he immediately addressed the wife, assuming that it was she. And in fact, it was the husband, who was a trans man, who had ovarian cancer. So again, really thinking about organ-specific care. The other thing that I might suggest about this question, though, about particular screening tools is, are there things that we may want to think about with this population, such as coping skills, such as resilience screening tools? Should we be screening them for depression at the very beginning? When we know that someone has a cancer diagnosis, we know that they're going to automatically, almost exclusively, they are going to have kind of an adjustment disorder, right, to this, what's a potentially life-changing diagnosis. So what is your practice in your organization? Do you screen all of your cancer patients for psychiatric, psychological wellness? If you do, then you would also screen all of your LGBTQ patients. So I'm actually really open to suggestions from the audience as well, and from ONS and from other authorities, from ASCO. Are there particular screening tools that, as we learn more and more about this population as a health disparate population, are there ways that we could screen them, being mindful of patient burden, right? Being too much screening, that would yield benefits in terms of how we care for the patient. I was intrigued by this question and think that there's lots of ways we can think about it. Again, I would reinforce organ-specific care and psychiatric wellness, emotional wellness, particularly with a cancer diagnosis, and that's regardless of whether you're a sexual gender minority or a heterosexual cisgender person.
I have to agree with you on understanding exactly what the audience member was asking with that question, but I think you gave a really good answer. And I think you've mentioned it a few times, but having it based on organ checkoff. I know I'm not saying that exactly the way you did, but in doing your assessments that way, and that makes things very neutral. So you're asking about the organs, and I think that that might be a really, good point that you brought up in regards to screening and how folks can go about that. So, David, I have really enjoyed our time together, and I think we could probably go on for at least another hour and talk more about just how oncology nurses can advocate and care for this patient population. Also, probably we would get through a lot of other questions that the attendees at Congress asked as well, but our time is limited. So I would like to finish our conversation with a few questions that I ask at the end of every podcast. And so I'm going to ask those to you now. And the first one I have for you would be, what are common misconceptions about caring for LGBTQIA plus patients and ensuring comfort and respect during treatment and care?
Yeah, that's quite a question, Stephanie. One thing that I was thinking about when we were on the last question that now relates to this question is, and I don't have an answer for it, but how do you assign treatment locations or room assignments when someone is transgender? So if a transgender person is being treated for ovarian cancer, but physically appears as and identifies as male, do you treat that person in a general chemotherapy clinic, or do you treat that person in the women's clinic where they're used to treating ovarian cancer? So that's not a misconception per se, but that's a perception that I do think that oncology nurses in particular might have to address based on the kind of treatment modalities that we use. Again, slightly related and slightly unrelated. Some of the testing that we use as we're working up our patients might be based on gender-specific norms. Hemoglobin comes to mind. Obviously, a pregnancy test or not comes to mind. HCG, which is used for a pregnancy test, might also be used to evaluate a man's response to testicular cancer treatment, beta HCG. So how do those, again, not misperceptions, but perceptions, how do those perceptions of the oncology nurse's understanding of how she works with patients in that disease category, so a young man with testicular cancer, a young woman who needs to be tested for pregnancy prior to treatment, a trans man going under treatment for what's considered a female cancer. What are those perceptions? What's the relationship to giving safe care, not hurting the patient based on how the laboratory values and other factors impact the patient? And then the patient's psychological well-being being treated in a particular clinic versus another, with, for example, a trans man being treated in an all-women's clinic would stand out. How do we protect that person's privacy and well-being during the treatment? Really thinking about what are barriers, what are misconceptions, what are perceptions that we hold based on our years and years of training in oncology nursing that now might have to be applied differently or analyzed differently based on the population that's in front of you.
What's something about eliminating barriers for LGBTQIA plus patients that's not often discussed, but you wish people knew more about?
I think I want to just address the fact that cancer is very, very personal care, how it affects your body, how it affects your body image, different types of surgeries and the impact of surgeries you might have to have, reconstructive surgeries. So I would say in the same way that we're not always comfortable with all populations, right, with heterosexual folks as well as homosexual or bisexual folks, we're not all that comfortable talking about sex and sexuality. So the same way that I would advise oncology nurses, maybe we all had this experience when we were young oncology nurses on the inpatient ward, that there was always a much more seasoned oncology nurse who was the one you would say, okay, ask Joanne, she'll go talk to your patient about sex, because she was comfortable with it and she'd been around the block and she knew how to do it. So I would like us all to be more comfortable to talk about issues that impact this population, but all of our population undergoing cancer treatment, that does touch on then body image, sexuality. Again, thinking about examples, if you have a man who's being treated for prostate cancer and he can't sustain an erection, but active penetrative sex is part of his relationship with his partner, that's a consideration. And we need to be able to talk to him about that. And we need to be able to discuss what are strategies, nerve-sparing ways, medical treatment ways that we can work with that and still treat his prostate cancer. Another example that I mentioned earlier would be a trans man who still has a vagina and a cervix, because that person has probably had steroid treatment for a virilizing steroid treatment. That person's probably going to have vaginal atrophy and vaginal dryness. And so you need to be able to talk very frankly about lubricants and dilators and ways that that patient might enjoy the type of sex that they enjoy as a trans man who still has a vagina and a cervix. So just being open and being comfortable to talking about what really matters to the patient. And I use the example of sex and sexuality, but there are a lot of things that matter to our patients, and we might be hesitant to talk to them about it or get them to someone who is able and willing to talk to them about it, like a therapist or a counselor or pastoral care or nutrition support. So really just identifying the needs of our patients and doing our best to meet the needs of our patients.
Thank you. Next question. What additional training or education do oncology nurses need to care for LGBTQIA plus patients?
So I think we did have a couple of questions that came through the QR code about training and education. There are tons of resources available to us. The Human Rights Campaign, and maybe that's something that we can do together with ONS, is put together a resource guide. So the Human Rights Campaign has very, very nice on-demand resources that if you want to say on your oncology unit, you're going to recommend that all of your nurses select just the basic 1 hour training and that they do it. And then they have the option, if they want to do more drill down if they want to learn about LGBTQ youth, or if they want to learn about cancer and survivorship for LGBTQ elders, if you want to look at more detailed information on health disparities and how that impacts the care that we deliver. The Fenway Institute in Boston, the LGBTQ network in New York, just tons and tons of material that are readily available to us. And I would recommend maybe that we put together a resource for nurses for training, because it's just readily available, and it's really just a matter. As I said, one of the things that was so encouraging about the turnout for this session was that you could really sense a genuine interest in people learning about how to care for this population. That being said, there is no shortage of training, no shortage of education that can be done. One of the ideas that they did at one of the places I spoke a few years ago, we had published the Seminars in Oncology Nursing, the first volume in 2018 on LGBT cancer care. And what that cancer center did is they did a journal club, and they read one chapter of that each month of their journal club, and then had the journal club to discuss it. So that's a resource that's readily available through ONS, and a number of publications that have been published recently in CJON and the Forum as well. So there really is just a really nice preponderance of training venues of different types. I mentioned in the session this beautiful documentary on intersex that's available on Amazon Prime. So if you wanted to learn more about the history of intersex and what it actually means and what the consequences are, that would be a resource. So again, happy to point people to resources and just to make them aware that there really are a tremendous amount of resources available now to oncology nurses to educate themselves about this population.
So our last question, David, is what are some additional resources for either patients or providers who want to learn more?
I think that there are a number of resources, some of which we'll be able to provide in the notes here on this podcast. Some of the ones that I would specifically bring to the attention of our listeners are position papers that have been published in the last few years. So in 2017, the American Society of Clinical Oncology published a position paper on how to provide culturally competent cancer care to sexual and gender minorities. In 2016, we published a white paper that came out of a session at Memorial Sloan Kettering Cancer Center in partnership with the LGBT Cancer Network in New York, where we brought together experts from across the country, and in fact, some from outside of the United States. And these people represented clinical care, they represented research, they represented advocacy, and we also had patients participating in the 2-day session to really identify findings and ways to move forward with education, research, advocacy, and quality work in caring for cancer patients with LGBTQ. There are a number of resources from Charles Kamen and his group on survivorship in cancer LGBTQ patients, so I would direct you to their work. Shane Megley's work from Boston as well on health disparate populations and the consequences, sometimes dire outcomes and consequences for people who are really at a disadvantage to receive competent cancer care.
Thank you, David, again for being with me today and for the information that you've shared with us and kind of recapping the session that we had. I think this has been a really valuable discussion, and I think our listeners will really enjoy it.
I just want to thank you for the opportunity, first for the session at Congress, which I was delighted to be invited to attend, and also for this podcast, which I hope will help to further spread the word that oncology nurses have always been known for providing patient-centered care as well as holistic care. And that's something that I'm sure we've done for many decades without putting a name to it specifically. But now we know that we are fully engaged and fully committed to providing competent quality care to our LGBTQ plus patients. So thank you again for the opportunity.
Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.